The osmolite is for people that have low calorie.
The osmolyte is
According to the website
people who
tonight.
can't eat.
Okay.
Yeah.
WhatsApp.
It's not low calorie, just that they're not eating and they
then-
need to maintain the weight. And by the way, just remember, when a person who is on GT tube feeding, receiving things like the osmolyte or what have you, and that patient loses weight,
Wait, that's
it's
no
a
good.
serious
Problem. Yes, because they're not supposed
because the
to.
patient
And is eating.
caloric intake has been what? Calculated by the dietitian who says this person needs X amount. And then this X amount is given in GT tube feedings. And most times these persons are GT tube feedings are sedentary, right? Meaning they don't move around.
No.
They sit down or they lie, so they're not burning up the calories. So why is it that they're losing weight?
It's true.
So now we come to they're losing weight, possibly the tube might pull out,
Top,
tube
yeah.
tear. A whole night the food been getting into the what?
The bed.
So the patient not getting it,
Yep.
right? The person who's supposed to put up something, they put up the correct amount. And they may have different reasons why person don't get it. But you now who will be, if you're already going to be the unit manager in a nursing home or something, you gotta find way. The dietitian said give the X amount,
LPS.
I'm not supposed to be losing
protein.
weight.
LPO.
So
LPS.
you have to investigate and find why.
Protein.
Is it part something going on with the feeding tube itself? Or is it that the staff not giving the patient? That's a GT. Now let's go to the patient. So they're finding now those Ensure cans and the 2 Kali chain and that sort of stuff in the patient's drawer. So if you're finding all that stuff in the patient's drawer and inside the closet, it means that the patient is not getting their
Proper
supplements,
nutrition.
and the supplements are being given for this patient to what?
Right.
To get their
Their
needed
calories.
They might be losing weight. That's why they put them on these supplements. Because most times you get your calorie, your caloric intake, and what have you, will come in the food that you eat. But in these cases, these patients are losing weight and they decide to put them on the supplement to bring the weight up. Now if they're being put on supplements and they're not getting the weight, it's a problem. So what you think, if you're finding the patient with the cans in the drawer, what you know as a registered nurse will do,
Talk to the nurse.
be very specific. Remember you said this year you're going to be very specific.
Okay.
Tell me exactly what you would do. Or what you think you should do.
Oh.
I will talk to the nurse in charge.
You are the nurse
You are
in
the
charge.
No, what I said that, like, the person that in charge to give it to the.
You're going to check with the nurse, but the nurse may, well, okay, let's say it's 3 times a day, so you may have 2 persons you got to talk to.
You gotta find out
I would check.
who signed in, who signed for it. Who
Exactly.
signed out, who signed for
Right,
it.
Great,
exactly.
you go with what? The signature.
Right.
And normally what they've been doing, because this has been happening, they've been putting dates on these cans. So when you see a date on the can, you could say whether what?
Who give? Who give?
You see the date and you correlate it
With the date.
to what, who signed it on the mark, and then you know who did give it or supposed to have given it, because it's signed that the patient received it, right?
Yes, and it's
And the
still
patient
not
received
giving.
it. So what you gonna do at that point?
I will talk to the person who signed for it and
To talk to her.
Now you guys have talked to people.
You want to talk
We're gonna talk to
Because
people.
you can go to administration with her.
I will have to
What
call.
have you guys
You're
done?
supposed to talk to her because you in charge the floor. You're supposed to talk to her to know what's going on.
This
If
is
you
what.
sign for something and then the patient don't
Didn't
have
get it enough
You're
hours.
supposed to know what's going on. If she just left it in the room and
Since you sign for it, you're responsible to see with your own eyes that the patient took it.
Exactly.
That's
Hey
what you're
guys,
supposed to say.
you guys just come forward. I don't want people out of the group. Come into the group, come into the circle or the semicircle or whatever you call it.
Professor,
Okay, nobody in the back.
this is what I would do. All right. I would look at the records and see which nurse is responsible for giving this client the let's say Glushona, all right, 3 times a day. I'll call them to a meeting so we can discuss the situation, and I will ask them to make sure that this client is taking the medication. Is drinking this thing in front of them. Then I'll reevaluate. All right, and see.
You got time for that?
Okay, that's what I would. That's what I would do.
Realistically, you got time.
That's what I would do. That's what I would do.
The question is, you being the charge nurse of the unit, the main charge nurse, the orange, supervisor, RN, manager, whatever you want to be, right? But you're in charge. And you'll be finding these nutritional supplements in the patient drawer. What would you do? Now, first of it indicated that they'll check the dates on the cans, and then check the date on the mark, and see who signed, and so you know who or the persons who are responsible for it, and they signed it, which they did not have it.
Oh.
It's a
So
white
what
dog.
are you gonna do?
Oh yes, yeah. I know what's going
It's
on.
a white dog.
I know what's going
Sign
on.
for it.
Mr. S.
Please, hold on. I find the guys are jumping up and talking.
No, you're not gonna write them up. Why would you write them up?
Yeah.
It's a white dog. It's a white dog.
No. I find 1, 2, 3. These guys are.
Yeah. Me too.
You're not gonna write them up.
Me too.
Okay. You don't hear my phone write them up right away.
Yeah. Good job,
No,
guys.
it's not a white dog. It's a white dog.
Stay with me. This is where you show. Stay with me. You guys who just got here.
How is it right
Believe
up?
it or not, it's part of what we go to transcultural nursing, where men are looked at as what? Usually the head of household. And unconsciously, in situations, most persons look to the men to take the initiative. Believe it or not.
It's
an
true.
unconscious reaction.
It's true.
For the way that the guy have to say.
That one take more
And
than
this is what?
30.
Just write them
Female
up.
dominated
You write them up, right?
profession. Isn't that so?
Because you
Amen.
can sign for something.
Exactly.
It's just
So I want to hear everybody
Cannot
voice.
be
Because all the front counter is everybody voice.
because when Toto Sam come, they come in for you.
So, I will follow up with what we're signed for,
The
what we're
glucose.
signed for that they would.
David.
Give them a verbal.
Yeah, you talk to them, bro.
That's true.
Verbal warning.
Yeah.
I'll get a letter, something to
Verbal warning.
Okay, you find who it is and you talk to them, so what next?
Verbal warning.
That's it. A verbal
You
warning.
give them a verbal warning.
A verbal warning.
Make sure your resident drinks.
Write it down, right?
What?
Write down you're gonna go woman, right?
Yeah, you write it down. You give the person a verbal warning, and then you write it down. So next time when it happens,
Now, since you sign for it, the nurse sign for it. The next thing is it's a write up.
it's a verbal
It's a
warning.
verbal warning.
You don't just write somebody up. You talk to the person.
If it's the step coming in the joy and find it, it's gonna be in my back.
Let me tell you something. If I go in a room and then I sign that I give Nadesh her glucina,
Yeah.
and then I just put it there because Nadesh was taking a nap. I just put it there, and then I sign for it. Before I go to Nadesh, before I go to Nurse Mark, I go to Nadesh to find out, did you receive it hand to hand?
I can sign for something that I'm not giving.
Exactly.
You gotta find out.
Make sure they drink it.
You got
Yeah.
Make sure the patient
Yeah. Exactly. Exactly.
in the side of the table.
So you have to wait until they take it. You still have to, but you still have to give the person verbal warning.
I get everybody put their I said, the 2 cents in. Of course, it's in their opinion. But remember what I tried to get over to you is that it is a supplement. And it's put on the bar for a reason.
Yes.
Ordinary, you have nourishment. A nourishment store will go to the bar because nourishment is come, you give the biscuits and the whatever, and the drink, and that's it, it's not in the bar. Right? That's nourishment.
Yes.
But supplements is something that has been recommended
To
and
drink
it's on the what?
more in the bar.
Orders. Because what's in the bar is in the orders.
Right.
And you have a doctor's order based on the recommendation of the nurse, the dietitian. And what you have found is that they're having these supplements in the drawer, meaning the patient is not getting it. Now, if harm occur, that is a person get sick and may have complications because they're not getting what? The supplement. Now, that's a big problem.
Yep.
Because it's
Even
sentinel
before
event,
the harm occur,
You say sentinel
because the
event?
person not getting it, it is a problem. Or
malnutrition.
when it reaches where the person got harmed because he didn't receive it, it's a huge problem. And he said it on the level of harm that
Yes.
occurred. Now, there's several things that go wrong there. One, the nurse is signing for something that she did not give.
Plagiarism.
She did not see or follow up and show that the patient did not get it.
So,
Two, the CNA that she entrusted it to,
then do the job.
just go and give it to the patient and walk away. Three, that CNA
Could get in trouble.
should be checking that patient dry every day.
Right.
It's part of our responsibility every day.
Right.
I'm serious. The CNA is supposed to check the patient on every
On
shift.
a daily basis.
And when you go, CNA go to the what? The patient draw. And they see it, they should say, nurse, you know what? This patient didn't drink it,
Right.
right?
Right.
And then the nurse will don't know what to do.
And that's
The
with
nurse now, as a corrective action,
the dietitian too.
right, should anytime the inform the CNA,
Yeah.
anytime you're going to be giving this patient the nutrients and they are not there, do not leave it
Leave it.
on the
Counter.
Table,
bedside table, wherever.
Right.
You take it back.
That's it.
So there must be a follow-up. Two, if the patient is there and the patient say, I'm ready for it. Okay, you're not ready for it.
I'll come back.
But if the patient say, all right, I'm going to drink it. It's in a minute. Open it.
Yes.
Always open the can. So he cannot take that can and store it. That's simple. That's the only can't store it. Story done. Check the drawer, which is a responsibility. Use a registered nurse who's in charge. You're supposed to ensure your staff are checking the drawer. Because our patients just put all kind of stuff in the drawers, right? Stuff that can bring roach, flies, you name it, things that can spoil it, then some people go and eat it after. All that sort of stuff. So at your level that you're aiming for, you have to know to take care of it. Now, if harm happened to that patient, you got to write that patient up. Not that patient.
CNA.
And
The nurse.
The nurse.
both have to be
Written up.
have this very action taken place. That's what is really need to be done.
All
Well,
right.
lots of time, oh, you didn't drink it? Shh, don't worry about it. And we move on, right? But in the real world of doing the right thing, that is what's supposed to be done.
All right.
Okay? That's
Okay.
what's supposed to be done.
Okay.
But as you know, time many places you work, the staff themselves is drinking sure.
Oh yeah. I love that insurance.
So what is a big thing about it? The staff themselves
Tastes good.
can write that to the patient.
It tastes good.
But what I told you is the correct and right thing to do. All right. I went to that there because now we were talking about treatment. But I want to show you something that's not going to happen when nurses give CNAs tubes of medications and when you're done
The cream on.
taking care of this patient, put on this cream for me.
24/7.
They never
The nurse is the one who's supposed to apply it,
apply it.
Mm-hmm.
right? But many times the nurse will say, put this on for me.
Wet to dry.
And they put it on. Now, when you give medication, just as much as when you give topical medications, as much as when you give the supplements. You have this on your what? Care plan, is that so?
Yes.
Whatever that topical treatment is for, it's on your care plan. And if you know your ADPI, at the end of your ADPI is what?
Evaluation.
So if it's not being applied, and maybe applied it correctly, then what can happen? The condition can get worse. And then if the condition,
1 minute, please. Hi.
Hi.
everyone. Anybody has any payment for us? Because it's that time, is, as a matter of fact, it's beyond that time for some of you. No? Nobody? If you do, we'll be upstairs. Or better yet, Mr. Bose is here.
you guys know that before you come into class, you're supposed to go and have this done. Tell it over and over. Before you come into class, go have it done, and then come into class. All right? So you don't have this type of situation.
Disturbance.
Not only disturbing, but some people don't want to any pain. There's a private thing between you and
Them.
upstairs.
Precisely.
All right. So treatments are supposed to be done by the nurse. That's your responsibility. It's not the responsibility of the CNA. The CNA only do it because what?
Courtesy. They like you.
Or whatever it may be. Now, when you do those treatments, what else you supposed to know? Go back to when we did the Mars. And all the things we talked about, the first thing you should know before you even touch the patient. That's how you found out that was the right patient, and you gotta make sure that you do what you're supposed to do, and make sure it's been done, the documentation, right? So what else?
You go to the file or the computer to check for what kind of treatment the patient needs.
Okay, you know what treatment, you see, it on the- and then you correspond with there. Same thing with the MAR, you correspond there. Drug to there, treatment sheet, right? Same thing go with the treatment sheet and the drug or the oil or ointment, and ensure that is the right one. But a lot of times, and stay with me please, a lot of time you get treatments as ointments.
Yes, you have to wash the
Now these
patient with warm water.
ointments come in different strengths.
Yes.
Sometimes you may have something that's a 1%.
Sometimes
Some is a
it's
2%.
Sometimes it's 4.
You have to ensure you look, especially you, right, that the percentage is the right percent as put down there by the doctor. And usually when you have dermatological situations, the doctor will have got a recommendation from the WHO.
The wound care, the wound care, the wound care
If you
specialist.
have those
The
dermatological
dermatology.
situations, not the wounds.
The dermatologist. The dermatologist.
Dermatologist.
The dermatologist.
Yeah.
They send the patient out to have the dermatologist give what? A consult. And then he will follow what the recommendations is. And sometimes the dermatologist will put 1% or 2%. But when the primary writes it up now, would be right up where he got
They
it right.
want.
Mm-hmm.
And then to match it.
Now, how would you pick up on that? When you, remember this patient have a skin condition, right?
Yeah.
And you have to do the care plan. Alteration in whatever, impaired skin integrity. When you come to the medical and the intervention, you have to put what the patient is on. How you know what the patient is on? You're going to look at what? The consult. And the consult will say exactly what it is. So now when it comes, you can say, oh no, this is not really what it is. And you look at the doctor's order, and then you're going to tell the doctor, hey doc, you put in 1%.
And then
Is
it
that
was
what you really
2%.
want?
Mm-hmm.
Because the dermatologist say he needs 2%. And a lot of times that happens. The doctors will be so, because some of them have 5, 6, 7, 8, 10 facilities you gotta run to.
Mm-hmm.
And see different patients. So they
That's
just
right.
write
White
them.
things.
Then you have a concern. So you need to look at that. What else?
Consult.
What about universal hand washing
Infection control remains
to control?
both the MARS and TARS.
Mm-hmm.
Hand washing,
The dressing was done, and when you're done,
Put the day and sign it.
Oh, that's
Put the date to
right.
sign.
Yeah, that's
Why?
right.
Why
So
put the date?
they don't have, sometimes they report that say it wasn't done.
Mm-hmm.
Just in
So you
case
can
the
snitch on
patient
somebody.
So they
like,
could see that you did it.
Also, you could be done too.
it
Yeah.
could be done,
It
but
could
they,
cover you that you did it.
no, if the patient sometime
I'm
have an
just saying.
infection
No,
there.
no nurse should. And this is one of the things that I always talk about. No nurse should have to cover their back.
Mm-hmm.
Because if you have orders in which you sign in for your patient, you've done it, you've done it.
Mm-hmm.
But what has been happening is that nurses will feel, I guess, overwhelmed, too much to do, and they've not been changing dressings. And the patients will complain, who's alert? I haven't done my dressing, like 2-3 days I haven't had dressing. And orders have what? Dressing daily. Once they change the dressing, night shift's supposed to change it. Night shift will change it. And as you said, the facility came up with, the facilities came up with a solution. When you finish the dressing,
Sign it and date it.
put one of those
Sign and
dates in it,
dates.
and you date it. But guess what? The nurse who's supposed to do it pulls off that tape.
Put a new tape.
Another tape, and that's what it is.
Put a new
And then
tape.
when you go to the patient, so you have, no, I had dressing for 2-3 days still. And you guys know that. I'm telling you.
I don't know. I don't know nothing.
Sometimes I do it.
Sometimes it's
I don't know
even,
nothing. I'm innocent. I
Why
don't
you
know
give-
Some of you all might have been doing it.
nothing. I'm innocent. I don't know nothing like that.
Just put it out, you got no time for this, I gotta go. Place a tip, yeah, all right. Especially if the patient can't talk and send them to themselves. All right? But how would you know that something is going wrong? When the
smell.
wound start to what?
Smelling.
Deteriorate. And please do remember that if a patient develops a pressure sore, which is called a decubitus ulcer, remember decubitus, you don't have a plural decubiti.
What's the root word for
It is always
decubitus ulcer?
ulcers, or decubitus ulcer. Okay? Don't take away the US and put the I and say that's plural. Decubitus ulcers or ulcer. Now with the decubitus ulcer, if a patient develops a decubitus ulcer in the building, it points to two things. Will you guys tell me what the two things it points to?
Bad care.
Not position.
Fluid accumulation.
Bad care.
You're not check.
Bad care, one.
Okay.
Two. Bad care.
Position.
Good, I will go down the line too. Because now the doctor has to say due to unavoidable, this patient will develop ulcers. All ulcers in the building is supposed to be avoidable. But when the doctor says it's unavoidable, then that gets you off the hook. If the doctor did not put unavoidable, it means that this patient who developed that ulcer is because of the staff. The staff did not
Inactivity.
call the patient in time.
Inactivity.
The staff did not clean the patient. Okay?
Bad skin care.
So right away, that points toward poor care by the staff. And guess what? You'll be in charge of the unit. So if you get of skin break because you gotta do investigation. Right?
Oh, yeah?
Because when the DOH comes into the building to do the inspection, because you send it out every time you send to that patient in your MDS stage where
You want that?
develop in-house. The right to really target that because it's not supposed to happen,
You want this?
right?
Yeah.
So knowing that, you have to ensure that your staff is turning and positioning patients because when a patient is admitted, what's one of the first thing they do? What do you have to do?
Check their skin,
A full assessment.
Grading scale, right?
Mm-hmm.
And once you identify that this patient is at risk for breakdown, you're supposed to put in place
Turn positioning.
prevent that breakdown from happening. And if that breakdown happen, it means that what? Your care plan is not working.
It's not, yep.
Because you put a care plan in place and it's not working.
Your staff,
And two,
your staff not doing the job.
because it's a sentinel event. Remember we did sentinel event?
Yes.
Malnutrition, loss. That's a sentinel event.
Mm-hmm.
So that there is going to cause an investigation.
Mm-hmm.
And you have to investigate. Once a patient gets a breakdown, once it hits stage 2, you got to do investigation. So now you use a nurse in charge and do it. You got to go back what?
2 days.
72 hours.
Mm-hmm. 3 days.
So we said 2 days.
I said
Then for
2.
your facility policy, you're
Okay.
48 to 72,
Okay.
72 hours.
Okay.
Most facilities go back 3 days.
Okay.
And we need all shifts. Now you got to get documentation for all of that. People got to do what? Write what?
Statement.
Statements. And don't think when you write them, that's because that's coming under what's called an incident report. You know, there's a difference between what? Incident and accident report. This is an incident report.
Mm-hmm.
And what you have is a nosocomial ulcer. And once it's a nosocomial ulcer, it means that something happens to cause a person to get it in the building.
Mm-hmm. In the building, it becomes nosocomial. Okay.
Again, it's not supposed to happen.
Sentinel.
All right? So, on your treatment records, will come across whatever treatment you initiate. And if those treatment is not given, it will deteriorate. And if it hits stage 3, it now must be what? It reported to the Department of Health. Because it's poor care, and this is a reportable situation. Most facilities don't want to report it because they don't want to get that type of thing in their heads. Breakdown happening. Also, when they send patients out to the hospital, patient goes out what? Skin nice and clean. Before they come back after 2 days, they got a stage 2 ulcer.
They happen at home.
Because they don't turn the patients in the hospital, they just have the patient
Laying
lying there.
down.
Mm-hmm.
And everything that you can think about that's not supposed to happen,
They happen.
it happens there. So the patient comes back with what? Skin break.
Breakdown.
And when the patient comes to skin break, you have to ensure that you're doing the assessment.
Yes.
You have to ensure that the skin break did not occur in the facility.
Yep.
They come back.
Usually the form they have facility or community, it's not in the facility. Within the hospital. You want to be sure. If the patient comes back with a redness, that's an unblanchable redness.
You have to report.
Don't just look it over and say you got low pressure sore. That's a pressure ulcer.
Mm-hmm.
That means the pressure ulcer started where? Outside the facility. And that worsened the breakdown. That's what I'm saying.
It's a first stage.
But if you did not put that down, the patient all of a sudden gets to stage 2, you got problems. So you got to do all these investigations and all that nonsense. You guys hear what I'm saying?
Yes.
That's the treatment. You have to ensure Now when the doctor writes the orders for treatment, have to indicate what the treatment is for. Don't just write, apply ointment, moisturizing cream, or what have you. You must have a what? What is it for? If you're given in the ointment for what? Right? In the ointment, you're going to put to what? Cirrhosis, which is dry skin. If the doctor's going to give you for a rash, he needs to indicate. That's why the patient needs to go to who?
The wound care specialist.
Because as registered nurses, you know there's something called ICD-10 codes. And that's how all facilities, hospitals, the doctor's office, nursing home, they're paid according to the code. And if the doctor don't put the name of the disease, you can't get a code.
Okay, 1 second.
So you want to ensure that the name of the disease is there. So they have their what? The code, the ICD-10 code.
Okay.
Look up to see what ICD-10 code
Hey. Look up ICD-10 code. ICD-10 is the 10th revision of the International Statistical Classification of Disease and...
All right, stop. One person, let's go.
Sorry about that. ICD-10 is the 10th revision of the International Statistical Classification of Diseases and Related Health Problems, a medical classification list for the World Health Organization. It contains codes for diseases, signs and symptoms, abnormal findings, complaints, social circumstances, etc., etc.
That there's the ordinary man in the street. But you guys get the idea.
Yes.
Even if you say, I spat on that man, I spit on him, there's a code for it. That's why I remember when I told you guys when you're writing, like in the care plan, and you have the what? The subjective data? That man was effed up. You put exactly that. Because there's a code that's going to go for it. And the facilities are paid by codes. So when you leave certain things out, because you got no time for work,
They don't get paid.
you're not getting that facility to get all that they should.
They don't want you to write it.
And one day, you're going to be in that position. You will be in that position. That you could be an MDS assessor, because if I'm telling you, if you're working in 7 nursing facility as an RN, don't work as no unit manager and then start the business. Just get your hearing or what have you, go do your MDS, the 3-day course, and then come back and earn much more money than you work for as well. And don't have to do all the work. You sit down in front of the computer and ensure that what? The CNAs do what they got to do. They ensure that they put in there with those late class ADL. If it's extensive assistant, total assistant, 1 person to 2 person, they got to put it in, right? In your the nurses got to put in the medications in your bar and everything, and based on the software, everything is put in. And you now be sitting there, you know the different drugs group, and you be like, that, okay, this is what, this is it. No. Come. Did you actually live this pair or you did not? Did they come and talk to you guys like that? Did you walk in the patient? Did you hold the patient? Because remember the ICD-10 and the money that goes with the late class ADLs. So you want to learn that. You want to know that. Because now you become a specialist in getting money. Them MDS courses is worth a lot more money than everybody else. Because they're bringing money into the area and you're registered nurses. There's only one MDS coordinator who coordinates all the activities. Everybody else is an MDS assessor. So become an MDS assessor.
Okay.
Right? I mean, you know what you gotta do, and you just sit in front of a computer, and you wear your long nails,
Here you go.
fancy styling.
Here you go. You just make my job lazy.
You know?
Money come.
Yeah, you just make my job lazy. 3 days court. Nobody want no dish.
And when you pass it, you get RNAC.
On it?
No,
No.
all you have to do is an RN.
Nobody want.
And you go
They
to
cause it. That's it, class.
No, you don't have to have
That
this.
one.
Oh, that's a change.
RNDS course.
Many years.
Oh
In
yeah.
fact, I was a director of company.
MDS.
Fuck the BSN. That's what we're doing next.
Yes, as a year.
Yeah, 3 days to a year? Come on now.
My friend gonna be a big
You
class. You
have
already was in the class, right?
No.
5 cases.
It's silly.
God, I did a lot. Quite a lot of cases. Facilities.
Excuse me. For the record, can I get the name of that course so I can write it down, please?
RN.
RNDS?
MDS.
MDS. Minimum data set.
MDS course. Thank you.
MDS. And the thing is with the courses, you're going to find you have them at specific places. They may have it and they may say, oh, by the way, before you go to the MDS, ensure you join an organization such as what?
American Nurse Association.
Join the association. So when you now apply to do certain courses, because you're a member of the Nurses Association,
Cheaper.
you get a little cheaper.
Oh, nice.
Because when I first did that course, it only cost me like $100 and something.
Nice.
Now,
That's not bad.
Thousands.
and when you go, not thousands, that's a lot of money.
MDS
When
course.
you
Nurses.
get that course, you don't just
Oh, we should just sit down and get paid.
you don't just like I got a course and that's it.
Just sit down
You have to
and
have
get
the
paid.
certification.
Won't do that.
But the only good thing about the certification for this is that you pay your money within a specific time, so you don't have to do it back again.
Nice.
If within the time frame pass, you have to go back and do recertification.
Question about that. I also heard about the being a specialist in the wound care specialist or something like that.
You won't care nurse.
Right. Who gets paid more to get a train? Who gets that training? Because
Everything if you want to become a baby nurse, a maternity nurse, that's a
Yes.
certification course.
okay.
MDS is a certification course. ER nurses is certification nurse. OR nurse is certification. Critical care, all got different certification. Psych nurses, certification. And what the certification is supposed to do for you is supposed to give you some more what?
Training.
Recognition and some more money.
That's right.
If I'm going to be hiring and I got 2 persons come to me for a job, let's say in psych, I'm going to hire the person who's certified in psychiatry than just hire somebody who just walked in. I guess you do the same thing. You
Right,
want
right.
people
Makes
qualified,
sense.
know what they're all about.
It makes sense.
All right? And that's what it's about. Okay?
So
So,
we do the
one
wound
thing
care
if you are
training.
in
We do the
long-term
MDS
care,
training and the wound care training.
right now,
both
seeing
of them.
that you work in the
You like them too?
CNAs and LPNs and new nursing homes, look at those MDS stories and you find out what it's doing. You know, like, they don't have to know that you do
I
this.
think it's like, how long is the wound care
Find out
course?
from them what they do, so you can learn, because if you stay within that environment, you want to do what? Upward mobility. And that's upward mobility, make yourself better. All right?
Thank you. Thank you.
And then at the end of it, when you, like how now you, when you graduate as an associate, with your associate degree now, you just have RN behind your name. What if the MS, the MDS, you'll get RN,
2 to 3 months.
RNC.
2 to 3
But
months.
now they call it
Not bad.
RNEC. Where you already nurse assessment.
3 days is better.
So, do it. But sometimes you go all the way down to Georgia, maybe sometimes they will have to New York.
Road trip.
That's when the dates are there. Right?
Road trip.
It's not something you can just go like that.
Manhattan.
Everything with its place there, down in the Vegas.
Take a trip.
I like
Take
to
a
when
trip.
you're ready to do this, because you have to go
Family
spend the time on the
vacation.
video. And they keep it, and the thing about it, this is American things capitalism. They keep it inside of a resort.
Mm-hmm.
So when you stay in there,
You gotta
the
pay.
resort getting money when you go and gamble.
Mm.
So, all that type of nonsense.
Not only
If you
that,
want
do
to get
something
yourself-
good.
And they give you, I think, 2 opportunities to pass the test.
Okay.
But if you don't pass the test, I'll give you 10 the certificate. If you don't pass the test, that's it. And then you lose your money after, I think, 2 or 3 tries. And that's it, you got to do things for.
Mm.
Right? Say again? 51?
How much it brought
Some facilities will run tend to come in as a assessor, and you come in to do assessment. For years, when I worked as a MDS coordinator, no, I wasn't MDS, I was a comprehensive assessment man, which is like MDS coordinator, but I had a little more, it's a king behind my name. But at nights, in the evenings when I left that job, in the Rockaways, I used to go down to Brooklyn, to the Bronx, and I do their assessment as an assessor. I was not a coordinator, I was an assessor. I just go to be there, and they pay me for each person, I get paid. So it's a good piece of money at the end of the week or the end of the month. So I will try to do as much assessments as I want. Anyway. One of the things you really want to ensure that with the treatment, like we were saying just now, when we started off with the decubitus person, is that a patient may have stasis ulcers. And the thing you're going to ask yourself, what the hell is stasis ulcers? And stasis ulcers are different from the decubitus ulcers. And for your, when you're talking about wound care on your treatment record,
Stasis also.
you can have your stasis ulcers, decubitus ulcers. You can have a laceration, right? Anything else you can think about that can come on your treatment record as related to dressings? Come on, what else you think could be related to dressings? Dressings. All this will come under wound care. I put wound management. So what else is it? Stasis, decubitus, laceration, anything else you can think about? Alright. That's it in surgical incision. So you have a surgical incision. After surgery, you have surgical care. What else do you think you can have? Just think about it. You don't have to be RN or just think of what you've seen as a CNA, what you've seen as an healthcare, what you see patients get. That will come under wound care up here. Do you ever see they put something around The GT site, because the GC site get all what? X what?
Excoriated?
Excoriated,
Excoriation?
right?
Excoriation.
So, you have that, right?
Yes.
These patients have to get it there because the tube might be too small for their ostomy. And you have leakage from their stomach. And what's coming out of the stomach?
The food acids.
What acid?
Acid.
The hydrochloric acid.
Hydrochloric
The
acid.
from the stomach. It's going to burn the skin.
Yep. Excoriate the skin
And
too.
so it's going to damage the skin, so you have to put what? A dressing.
A dressing.
But do you think a dressing is all that can help there?
No. Filtration.
But what? You look very, very, very attractive today.
Woo!
I don't know, girl, you gotta be careful. Stop. All right. What do you think? With this the exfoliation, you think it's just putting on a dry dressing?
Skin
There you
practice.
go. You're looking for the skin
practice.
barrier. And yes, you have the script pep. It's the same thing.
Yeah.
You know, the patients who are incontinent, you have a cream that you apply, right?
Yes.
Yes.
Times or what have you, after perineal care. That is what? A skin barrier.
Yes.
Prevent what? Urine, acidic acid from damaging
Their
the
butt.
skin. So you want to prevent damage. So you have to derive the appropriate treatment based on what's happening to the patient. Stasis ulcer treatment is going to be different from decubitus
Decubitus
ulcer.
ulcer should be.
Because decubitus ulcer is pressure related. Pressure over bony prominences. Right? And we know with the decubitus ulcers you have the stage 4, 1 through 4. And then you have what?
Unstageable too.
Unstageable. And why do we call it unstageable? Come on, we did this before. Why do you call it unstageable?
It's tunneling and everything.
Come on, no, give me the rationale. Why do you call your ulcer unstageable?
It has multiple islands.
Don't tell me blanco with.
It has multiple.
Better
It
word.
has different islands.
It's not an S-star.
Oh, yes. Okay.
And when S-star is there, you don't know what's under the S-star. If you have the tunneling or if it's just dry. Before, maybe 4 or 5 years, 6 years ago, that S-scar used to be turned at stage 4. And guess what? The facility get more money for patients who have stage 4 because they got to use more time and more what? Material. So the facility get paid more. Stage 4. But the government decide, hey, that's too much money. Everybody seems to get S-scar. So they say unless you see what's under that S-scar, don't put it to the stage 4.
It's unstageable.
So they give you one set of money for that. All right? So that there, unstageable, and the next one is what? All I tell you, y'all guys like looking at me, you know. That's all the things I talk about right now. People just look into the blanks here. I said stage 4, unchangeable, what else? Listen to me, man, come on, stay with me, that's what I'm saying. You guys just look at me. There you go, say it again, say it loud. Tell them, D2 who? DTI, what's DTI? Deep tissue injury. And those are the ones that we were talked about. You must know those stage 4s. You are going to be RN student, RN. You got to do assessments. And you don't remember what's DTI, guys? You gotta remember DTI. Come
Deep
on.
tissue injury.
Of course, deep tissue injury.
DTI. I will never forget now.
All right, and then
Deep.
the stasis ulcers. When you look at the stasis ulcers, you start to think about certain conditions.
Deep tissue injury.
For the stasis ulcers, it's not about pressure any longer. It's about what? The blood supply.
Yes.
So you have PAD. And what is PAD? Peripheral artery disease.
Disease.
And then you have PVD. Peripheral vascular disease.
Peripheral
And what are
vascular.
those? Those are things such as diabetes.
Yes.
So you have to know that to know what type of treatment. Then you have the situation, I'm going to move on from that because we did that before. You have lacerations, right?
Mm-hmm.
And laceration can be caused by what?
A cut.
By,
A cut.
it could cause by
Cut by a
accident.
knife.
By accident.
Can get cut by a
By a
knife,
knife.
Accident too.
can get hit by a
Blunt object.
a wood or something.
A blunt objects.
You can get hit by a car.
Okay, that's so.
Right? All those can cause a laceration,
Mhm.
but it's going to be different from a surgical incision. And the surgical incision is when that what? The surgeon had done surgery.
Mm-hmm.
And you guys remember this one, gotta remember this one. Because when we talked about the surgery, we talked of one specific surgery that couple things can happen. We talk about a laparotomy. And with a laparotomy, that's what you say with what? A dehiscence. And from a dehiscence, it goes into a, tell them again, evisceration. We did this, right? What's a dehiscence? What's a dehiscence? Oh, shh. What's a dehiscent over here? Guys, it's over here, quiet. What's dehiscent? All right. See now the bright people over here. Tell them for me.
Oh God.
Well, what's
They
dehiscent?
close us.
It's an open
Opening of a surgical wound. The surgical wound is not supposed to open. So that's dehiscence. Some people call it burst abdomen. Meaning the stitches burst open.
Splitting open.
Right? So instead of forcing out a burst abdomen.
Surgical wound
And
opening.
then what's now happening is the what? Evisceration. So what's evisceration?
Extrusion of viscera or
When they have
intestine.
all the stuff pushing
Coming out.
coming out. And you guys are so upset when y'all look at the picture. So people shouldn't forget it. Because you remember looking at the image of this thing gut pushing out and all sort of stuff. I've seen people gut push out
Mm-hmm.
after they get chopped with a machete. But this is not a machete chop. This is somebody who went under surgery and after surgery
Put exclamation.
they may have an
Excoriation.
infection of the site,
How you spell it?
and because with the infection
ES.
you could have the
Covariation.
tissues and then break away and then what happens?
INTI.
That'd be evisceration.
How you spell excoriation?
And what not only
Excoriation.
the infection can cause a dehisceration, but you know that with the positioning, is that so? Different surgical and medical positions that you
Excoriation.
use for patients. And when we talk about the positioning that we use, we said also that if a patient is having that same laparotomy and they have to cough, what do?
The shield.
They splint.
Yes.
That's the word I give to you, splinting.
Splinting.
When they cough, they splint.
Splints. Not
Show that you will not have that dehiscence or the burst abdomen with the distillation.
Okay.
So that would be that. Every time you talk about this, we said they got to use the what? Protective barrier. The exfoliation.
Yes, sir?
The first one.
Now, remember just now we were talking the ICD-10 codes? And we said for everything you have ICD-10 codes. If a person smiles now,
You see it
you
here?
get ICD-10
The
Alright?
Hissens?
Because that's how
That's what I'm showing.
everything that happens in the nursing
The
home,
Hissens.
get paid through ICD-9 code.
Try to spell it.
ICD-10, not 9. You get to change it up here from 9 to 10. Like really did. So ICD-10 code. Again, as RNs, you guys have to know these things. MDS and ICD-10. You walk in the doctor's office, you gotta know that. Everywhere, you gotta know what is it. And just to make a, can you find me the ICD code for stasis ulcer?
Show me the ICD code for
Left.
Stacy's ulcer.
Which toe?
I found this on the web.
Which toe? The left got 5 toes. Let me see if anybody got more less than 5 toes. So pick a toe on the left foot. Left fifth, left fourth. You pick one and find the ICD-10 code for me. On the left foot, find the ICD-10 code for anything on the left foot. Left big toe, left heel. Remember the foot starts from your ankle going down. So tell me something, find me a code for anything on the left foot. And give me the number.
I see ICD-10. Code is L9
For what?
L9
You gotta tell me what the code is for.
first. Okay. Disease of the skin and subcutaneous tissue.
Disease of the skin and size of foot.
Okay.
Not this foot, for the left foot.
All right.
I find the left foot too.
Left foot what? What's wrong with the left foot?
Pain.
Pain. So you have left foot pain. So if you have left foot pain, what's it called?
M79.
M79. Now look for the left,
Fifth toe.
all right, left fifth toe, or the left hallux.
It's the same thing. It's M7.
Pain, left foot,
So
left
is that
big toe, or left hallux.
Left
Pain.
fifth toe.
ICD-10?
It's M79, 675.
Yeah.
M79 what? That's the left foot.
675.
Right. So you see the main thing here is what? Left foot pain, but then when you talk about parts of the foot, you have the M79, but what else you have what?
672.
675 for the left fifth toe.
Okay, for the left foot.
So it now can go now to the left toe nail. Look for the left toe nail for me.
Left toenail. Okay. ICD-10 code for left toenail.
It's
S91.2028.
So what that tells you?
Every part.
They have one for everything.
Everybody have a code.
Every
part of
your one toe
have a code.
got several codes.
ICD code in there.
So you can also say the left foot.
Yeah.
The left foot is like a general thing.
We don't.
Then when you go into specific part, it will tell you, oh, you're talking about the toenail. Then what about, and then with the toenail itself, it goes further. The inner aspect or the outer aspect. So ICD-10 code, ICD-10, sorry, it's very large and very specific. Because the doctors or whoever the podiatrist, because a lot of these are hit the podiatrist. You gotta have those doctors. And if you are MDS coordinator or assessor, you gotta know this. That's your life, ICD-10. Okay?
Okay.
All right, this is just to let you understand about that when it comes to treatment. Okay?
With anatomy.
Expiration, incision,
Like that
laceration,
too.
and all that sort of stuff. That will come under wound care. And usually, the primary doctor, even with the wound care, the primary doctor is not the person who comes up with the treatment. Is it who?
The wound care doctor.
The wound care specialist
Yeah.
who works with the wound care nurse. And usually in facilities, the wound care nurse is also the rehab nurse. Meaning she also coordinates rehab activities and the wound care.
And physical therapy as well?
Yes, that's what rehab is about.
Part of it, yeah.
Physical therapy, occupational therapy, speech therapy.
Yeah.
She oversight on all of it. Plus the wound care. And the care is not too straight.
How long is that
Well, not
cost?
straight to say, most of the wound care nurses you find is around here is who? Filipinos.
Philippines.
Because they go where the money is.
You're not money.
And
So we
just
gotta go then.
coordinators, gonna be them. The directors,
So we gotta go.
gonna be them.
Yeah.
They don't mess around with being no floor nurse and medication. They don't do those things. I just want to say you guys as black people, put yourself together.
Amen.
Alright? Other people come from other places and they go and get what they want. And you work hard,
Look, we work
they
harder.
work less and get more money than you.
It's true.
That's right.
Okay? And you've been here all your life. So,
We gotta come together.
just tell you guys, well, and I do hope that you guys have took the opportunity of looking, this is the last, by the way, the last day of the month. What? Black History.
Black month is
And I hope you guys look at Black History 2022, African American Nurses in History. We should look that up, and then you're going to find that for this year, this month here, we have the nurses who are African American descent, talking about all the problems they're having getting jobs, maintaining jobs, because of their skin color.
It's true.
You're going to be looking into situations where you go as a qualified person, but if you cannot put that image out there when you go and walk into an interview, and you got a Caucasian, and you go up there, and you may be even more
Qualified.
qualified than that
than them.
person, that person gets a job.
they don't have recognition
That
themselves.
person will get the job. About years ago, maybe 6-7 years ago.
What if you're a citizen?
Yeah, but 8 years ago, there's a facility in the Bronx that wanted a staff educator, assistant director of nursing. And they called me up. And when they called me up, they had also a Caucasian. She had her master's and she said she did a lot of stuff. And so they said, okay, what we're going to do today, because only one we can get. So they get people from the different departments, put them to sit down in a class and tell both of us, prepare something and talk for 5 minutes. So we prepared. I went up. I talked. She went up. She talked.
Nonsense.
Next day,
She got the
they called me. Please come in and do the paperwork. We want to hire you. That's all. When I was there, she was there too. They hired both of us. And they put her to do something else. It's only because of how I
Presented yourself.
and the people, like the director of nurses, that even before I moved, oh, we want him. Other nurses are saying, they're not saying that, right? But the Jewish person's here who's sitting, because she's Jewish.
They have to give you place.
Okay? It was me, they kick my black behind out.
You know, they
Well,
did
guess
that to
what?
me too.
They take me, but they make sure they kick her out.
When I go
They
somewhere,
kick her.
oh, we want him. Oh, yeah. Oh,
And she
black
did
man.
it.
Oh,
It was
they're
selling
going
nonsense. Till eventually kick her
Nonsense.
out after the 2-3 months.
Oh, wow.
Because what they gave her to do, she didn't even know what the hell she's doing. So how you present yourself is very important. Don't let nobody back you down into situation. Don't be a loud and aggressive leader. Overwhelm people with knowledge. Always overwhelm people with knowledge. Don't be a very loud and aggressive. You don't have to tell people, oh, well, I know this and I this. No. Remember the thing I tell you guys? Speak your truth and speak it what? Calmly.
Less desperado.
Right? Speak your truth and speak it calmly. But speak it with authority. And as RNs, you have to have that assertiveness. Anyway, I was saying, please, this is the last day of the month. Always look into who you are as a black person. Don't carry anything on your shoulder, because we should treat everybody as equal, regardless of the color of their skin. But we got to be at the same time realize that in America, there's a lot of inequalities still exist. Okay? A lot. Quite a lot. And you will come across it at times, but let that don't deter you from who you want to be or what you should be doing. Okay? All right. On the last day, we had looked at apical, right?
Yes.
We had looked at what else? Carotid. We all know what's radial. Stay with me. This is still in administration. This is still looking at medication administration or treatment administration. But this is solidifying what you did last week. So if you know the apical, which is the most what? What's the apical? The most accurate. So if you have the most accurate, right? And when you do the carotid, you do it when what? Emergency, unresponsive. You go up.
Yes.
Are you okay? What's up with you, man? Whatever. Right? Important to respond. Carotid. Breathing. No pulse. No respiration.
Right here.
911. You know that, right? And we know the radial pulse. You put your finger there and you check for what? Red, rhythm, and volume. Three things, right? But when you do the apical, you only check it for rate and rhythm. You can't check for volume, because you don't hear volume. When you feel the pulse, you can feel if it's steady, if it's strong, if it's bounding. That's the volume, right? Don't hear it. Now, when you're checking the apical, you will also check the radial. And when you check the two, which should be done very close together, or that's done with two persons. And when it's done at that point, you will be checking for something called a pulse deficit. When you check the apical pulse, you check the radial pulse at the same time if you have somebody with you, or immediately after the apical, you go to the radial and you check and you calculate your pulse deficit. What is a pulse deficit? It is the difference between the
Radio and the apical.
apical and the radial pulse. What it tells you is that the amount of beats and the difference between will indicate that this patient is not having enough blood going down to their periphery. It makes sense?
Yes.
So when you have something like your PADs and that sort of stuff, you want to understand. I've seen a lot of blanks here. You guys understand what I just said?
Yeah, PAD.
That's you. Everybody understand what is the pulse deficit? Do you understand why we do the pulse deficit? Everybody look up pulse deficit.
Pulse deficit.
I didn't get that. Could you try?
No, I said pulse deficit.
Sorry, I'm still not sure. Sorry, I'm still not sure. I found this on the web.
What is a pulse deficit? A pulse deficit is May I read it?
Oh, you didn't read it loud. No. Okay, well, I want to hear you.
All right.
I want to hear you. All right, go please, go.
All right. What is a pulse deficit? You may ask. A pulse deficit is a condition that affects the relationship between the pulse and heart. It can be very dangerous if not treated properly. No, somebody else read it. I didn't find it. This is more context. It's not actually
Pulse
giving me a...
deficit is a clinical sign wherein one is able to find a difference in count between heartbeat, apical beat, or heart sounds, and peripheral pulse. This occurs even as the heart is contracting, the pulse is not reaching the periphery. This can occur in few clinical situations.
Okay, I got it.
All right. Now, if you listen to what she just said, right?
I didn't understand what you said. That's right.
When you have a pulse deficit,
I didn't understand.
it could indicate a problem. A problem for what you hear, because when you listen to the apical, that's the true beat, which is the heartbeat. But now you're getting a reflection of the heartbeat.
Pulse deficit is different than heart rate
When
and
you
pulse
feel
rate
the radial pulse.
when both are checked simultaneously.
When you listen to the apical pulse, you auscultate. You listen to the heart rate, you what? Stethoscope. When you feel the radial pulse, you feel perturbed. And then you look at the difference. And that difference that you see can indicate the person is having
Decreased cardiac output.
problem, including how fast and how many, basically what they say when you have, like, if you have difference of 10, difference of 80, it says that 10 or 80 beats never reach to your periphery. The difference, it doesn't matter. Again, what the heart does, the heart pumps blood. So that's a beat. Bam, locked up. So locked up. It beats. It sends the blood out. You listen to that, that's a true number you're going to get there.
Yes.
Because it's actually hearing the heart beat. But when you feel now, that is a reflection of the heartbeat. So it is not exactly the same thing that you hear at the same time. So when you do the 1 minute of both, and what you get is a difference, whatever is the difference, means that that amount of beats is not reaching your periphery. The heart is beating, but when you feel down here, it is not that amount, the blood is not reaching. That's why you're not getting that. Are you guys understand what I'm saying?
Yes.
So now take out your stethoscopes and this, please. and you do it to two persons. But before you do it again, like what we did with that, get a sheet of paper, print your name at the top of the sheet of paper. Again, print your name at the sheet of paper. Then this time you get the patient that you're going to be doing, two patients. You're going to do the what?
The radio and the epical, and then you're gonna find out
We're going to take
the pulse deficit between the two.
the initials of the persons that you're doing, and you're going to do the pulse and the apical, and then you're going to give the pulse deficit to the side of each. So, guys, if you look up here, because I want no little piece of scrap paper from anybody. You can bring me scrap paper, you keep it. Right? This, your name, right? On in here, apical, radial, pulse deficit. Today's date. Then, down here, right? Honor one will be what? Apical,
You got a strip, okay?
radial, pulse deficit, comments. What do you mean by comments? What you observe about that person that you do, and what can possibly cause that person to be somebody inside. Now, what do you remember the Come on, what do you remember what the epical calls?
Give me my pen when you're
Take
done.
off your jackets. Don't see nobody do anything with jackets in here. Epical pulse. What do you remember the epical pulse? What do you remember how to do the epical pulse? That's it.
For a few minutes.
Where do you put your stethoscope? I don't what?
The fifth intercostal mid-clavicular.
And the fifth intercostal
Mid-clavicular.
mid-clavicular. Put it down there. So, start. Please. Don't anybody tell me you don't have stethoscope. You don't have whatever. Don't tell me that. Alright? So, because I did tell you guys when you come into classes, you should have one.
Oh, Lord. What does A stand for?
You can say it.
And the person who is doing it need to what? Stand. And not sit.
Yeah. AR pulse deficit comment. What do you need? You wanna start on me?
Are you guys ready to start? Let me know. When you're ready to start, let me know so I can get you guys stuff to work with.
Alright. I'm gonna start with you. I'm gonna do Mercedes.
That's only two, he said.
That's it then. I'm done. After that.
Two, right?
Two.
Two persons.
Yeah. You can do me and do Mercedes. That's it. A R P D comments. Okay, I'm ready.
Mercedes has an ethical rating of 85 and a radio rating of 70. So post deficit is 15. Post comments is patient has a post deficit of 15. So patient still fine. And everything.
The patient still what?
Still fine. So Barbara, ethical 93, rating 76. Post deficit of 17. I think myself the same thing. Patient has a post deficit of 17. Patient still fine.
All right. Sandra?
Just doing too much.
I have frustration. The airport pulse is 71. The radio pulse is 69. And the pulse deficit is 2. Patient is stable, is okay. Beside the different between the ethical and the uniforms, patient has no active distress at this moment. Okay, second patient, 82. The epical pulse is 82 and the radial pulse is 70. And the pulse deficit is 4. Patient is complaint for now for acute, for dizziness, and patient is
What was the pulse deficit in that one?
4.
What was it, 4? What was the apical pulse?
82.
And the radial?
That's 3. 79.
Guys, you gotta listen.
Why?
Where's your pen? What you gave me?
I don't know. What did you do with it?
All right.
You took it. You can take it back. Then I still have it. I'll find it.
Transform it because you make sure you make it next in line.
This is one.
I do not have any comments. My name is Natalie.
Wait.
Not Mr. Klasky.
Why are you gonna start off something by saying you don't have any comments?
Okay, my name is Natalie Lindsay, and I'm going to work with Mr. West, the date is 2/28/20.
You use a pen? You come with a pen, right?
No.
Your
first
pad
patient.
comes with a pen. So.
Yeah.
You're not supposed to use the name.
Just initials.
Epical 89, radio 84.
I'll buy you another pen.
I'll kill you.
Was deficient 65. Patient very alert,
No comment.
no complaint. Patient number 2, epical 85, radio 75.
80.
Easy.
Pulse deficit.
5. Yes.
How much is the apical again?
Epical is 85. Radio is 75.
Are you at 5?
10.
Why you guys not telling me
10.
when you're saying something? You guys, am I the only person in the air? Lord have mercy.
I want to embarrass.
Okay.
Mine is good.
Just have a seat, please. As a nurse, you must be able to listen to your patient. Right? Listen to things that they say. When you're in classrooms, you want to listen to your student colleagues, all right? All right, what I didn't hear from everybody, what I didn't hear. Barbara's asking, let me see if I'm here. Barbara, you can let me hear what you want. See that you asked to go. Come, please.
Yeah, he has good ears. He heard you.
I just wanted to.
And she whispered
You
too.
just said you present, so go. Oh.
Reported on Ann Barbara Saint-Hilaire. Day 2/20/28 to 2020. Patient room 212, Les Washington.
No name.
Time
No
taken.
name.
He said no name.
Initial.
Initial. MS. Time taken, epical pulse at 2 p.m. was 85, radio pulse was 70, PD 15. Patient had a deficiency of 15. No complaint. Patient mentioned she was drinking iced tea and was relaxing watching TV. Room 220, initial Y, time taken 3:30 p.m. 90 for epical, 77 for radio, PD 13. Patient is stable and oriented. Patient is stable and oriented. However, we're still going to monitor this patient because the patient was complaining in the morning shift that the patient didn't feel good. So we're still going to monitor to see why we have a number of 13. A gap of 13.
So I didn't hear I didn't hear what I want to hear.
Spit it out.
Which is?
Everybody's saying you're going to monitor. My question is, what is it you're monitoring for?
To get a closer to see the gap, to me, the gap was kind of
What is it you're monitoring for? Think about it. Everybody's saying you're
Patient's
going to monitor.
condition.
What is it you're monitoring for?
It's the funded.
If you're going to be monitoring because you saw something in the pulse deficit, what is it that you're going to be looking for?
The numbers?
Sign off.
Sign off or whatever.
Don't guess. What you need to know is what?
Sign of dizziness.
What are the causes of pulse deficit? Then when you find what is the cause of pulse deficit, you're going to get to what? The signs and symptoms of pulse deficit disorders. And then you can say, what is it that you're monitoring for?
Pulse deficit.
Also, what you need, stay with me guys, it's all right, you can always fix that. What you be looking for, what I expect to hear from you guys was, if a person have a pulse deficit, it means that the blood supply to the periphery is missing 17 beats, 10 beats. How much is the deficit? That's a lack of blood. Blood pump, or pumping of blood to that.
Deficit of 3.
This is the central, right?
Not bad.
The central station.
Yeah, it's not
And the
bad.
central station pumping out to other places. So this is where the origination. So we got the actual beat. But when it reaches down there, it should have about the same number or close to it. But if it's wide, that's why we call it pulse deficit, as indicative of something that's going on. It means that enough blood is not going through. So what is the cause? What are some of the causes of pulse deficit? So when you're going to be saying, I'm going to monitor, what is it you're monitoring for?
Signs of pulse.
You got to check and see. That's what I want. That's why I tell you guys to check or write in comments. So you know what is it. Don't just say, I'm going to monitor something. What is it you're going to monitor for? Remember you do the care plan and you say put your interventions and the question is why? Remember that? Why did you say you're going to put the stick up in the air? Why? So if you're going to say you're going to monitor, why? And what is it you're going to monitor for? But you can only monitor because you don't know what is the underlying cause, because it may have different causes, right? So if you know what is underlying cause of it, you can what? Monitor for those signs and symptoms. Are you guys with me?
Yes.
Or it's something that you can fix. Now we have something called a widening pulse gate, right? The widening pulse?
Widening pulse.
You guys know it's a widening pulse, right?
Yes.
We talked about that too. So what's the widening pulse? What's the widening pulse?
Pulse pressure is a different system of pressure. If you just have the number of your blood circulation.
Widening pulse.
So it is a difference between what?
Systolic
and diastolic pressure. So what you got to know? What is considered the normal? What is the normal range that's acceptable? We know that when persons have blood pressure, you have different numbers, right? 120 over 80, 129 over 79, still in Gamba. Then you got 130, 1 to 139. What's that, 130, 139? Over 90. And then you got 140 and above over 150. Those are different ranges, right? And then you have your primary, then you got your secondary, then you have your hypertensive crisis. This is where you talk about hypertension. So we talk with high blood pressure right now. So the thing is, with the high blood pressure, what is a normal, because what is a systolic? Based on your knowledge of your anatomy and physiology of the heart, what is a systolic? What we did recently, we did this recently as 2 weeks ago. What is it? What is systolic?
That's when the blood is pumped from the aorta to the rest of the body.
That's when the blood leaves the aorta. What will affect the systolic? The systolic is the highest point of pressure exerted on the arteries by the contraction of your ventricles. We know this, right?
Yes.
The ventricles of your heart. What will affect the systolic?
If the left ventricle is enlarged.
If the left ventricle is enlarged, good.
Yeah.
If the ventricles weaken,
Yes.
like
It
in
could
what?
affect the two sides.
Congested.
Yeah, but what? Give me a name. Like a what?
Arteriosclerosis, some kind of disease.
Articular sclerosis, that would be the weakening of the muscles.
No, not the ventricle.
Ventricles is the muscles that chamber has muscles. The myocardial muscles. All right, so if you had said cardiomegaly, an enlarged heart, all those big, it's weak.
Yes.
If you said that, I can go with that. But what you're looking at to get the contractions is something we did recently. When we did the electrical conduction system, and the pacemaker sent the impulse that caused the atrium to contract. And then the pulse go on to your AV, which slows down that pulse rate. So that what? The chamber can full up. And then it goes on to your bundles of His. And to your Purkinje's fiber, by then what? It's squeezed. And that's the QR that you're going to see, right? So it's squeezed out. And at the same time, the atrium going to fill. You can't have both squeezing and set, but that's your beat of the heart. That's what causes love dog. And this is where you get to remember your arrhythmias. Because what? The heart is not beating right. And then it's got to put what? A pacemaker in. Implant the pacemaker. That's how we get your arrhythmias and your atrial fibrillation. And the atrial fibrillation is what?
And the heart is fluttering.
Meaning, this electrical impulse is not going right. So, atrial is the top part. It's fluttering. So it's not giving the chambers enough time to what? Fill with blood.
Yes.
And then if the heart is not filling with blood to push out into systemic circulation, what is going to be something you want to look for? At the heart, the level of the ventricles, what's something you're going to be looking for? You're going to look for ejection fraction. How much blood comes out? And you know the normal ejection fraction is what? 50 to 70. But if the thing freezing like that is not pulling up, it's not going to be 50 to 70. It's going to be more like 30 or 40. And you know you have a problem, right?
Where's my pen?
And guys, I want you to think along that line. Think about what you know and put it together like in this situation here. When you do this.
Where's my pen?
What caused it? Why is this so much more important than when you do the pulse? The pulse. You guys with me?
Yep.
All right. So we go to the widening pulse rate. So you want to know the widening pulse. What is pulse, right? This is, they didn't say widening what? Blood pressure. They say widening what?
Pulse pressure.
That is what? The beating. And you know when they said that something is, it's sending a message? Electrical, they say what? Something is pulsating, right? Like the beat of the drum is what? Pulsating, right? They show you something that is moving, they said it's a pulsing movement because like that, right? It's consistent, it's pulsating. Now keep that in mind. What you need to know now, what is the normal, or considered normal range between the systolic and the diastolic? That's the only way you can know what we're talking about.
What is the normal range between systolic and diastolic
I
pressure?
get accustomed to jumping on those computers and searching on those computers. Please do get a navigate. That's your passing right here. Yes, you got in front of you. What will make you pass? So what is it?
Normal is systolic less than 100, 120.
Right. What's the difference?
What's
What is the difference? Normal difference between.
What is the normal difference between the systolic and diastolic?
I want to know what's the difference. So I can tell the difference between what?
The difference, the top number systolic minus the bottom number
The normal
diastolic.
is 120.
The pulse pressure, for example, is the if the resting blood pressure is 120 over 80, the pulse pressure is 40.
Repeat that again.
They said the top number systolic minus the bottom number diastolic is the pulse pressure. For example, if the resting blood pressure is 120 over 80 milliliters of mercury, the pulse pressure is 40, which is considered a healthy pulse pressure.
Okay. They normally say the average blood pressure is 120 over 80.
Yes.
Right? So when you look at, and you see it's going more than 40 and above, I mean, you got a concern, right?
Yes.
And then the next question will be what? What causes widening pulse? That'll be your next question. Guys, please put this down because this is what you're going to read about. So if we get tomorrow, we can talk about this. All right? So you can read some more tomorrow, tonight or tomorrow. All right? But I don't want you just to know that you do blood pressure or high blood pressure. You want to know
What was the
when
question
you
you
do
just
blood
asked?
pressure,
What is
things that can happen that is not related to saying you got a high blood pressure, which is hypertension, or you got a low blood pressure, which is hypertension. It has nothing to do with that. It has to do with the widening and what can cause it to get wide.
Look at this. Can you read that?
All right?
What
So for this exercise
all
now,
the what? White?
She hear me
for
all the
this
way over there.
exercise now, you take out your what?
She hear me all the way over there.
She
Your
hear
blood
you?
pressure
All the way over there.
apparatus, and you check and you do not tell anybody what you've got. Now,
What?
you go do the blood, don't tell nobody, don't
Yeah,
tell the person
I'm
what you're doing it too.
I'm gonna
How
be a
much you
patient.
got?
Me
I
too.
do.
What's the normal widening? How do you know the widening?
Causes whitening cold.
Thank
What
you.
pose the
What you do two
Type
patients.
for the one, yeah.
What causes widening pulse
What you
pressure?
get.
Wine.
And at the bottom of the same sheet that you're using, on the next line, you put
What
widening pulse monitoring. And then the same thing, you're gonna put what you want it in systolic, diastolic, and widening pulse. You guys agree? The first line where you had what? Apical, you're gonna put.
Okay, now I'm doing a patient.
The second line where you had radial, you're gonna put what? Diastolic. And where you had pulse deficit, you're gonna put there widen pulse.
The first part is gonna have radio. Where I had apical is gonna be radio.
Well, under apical, you're gonna put systolic.
Systolic, and then
And then under the next, which will be your radial, because you're gonna use the lines.
The
So
same
on
line.
here now,
Same
on the
format.
same line. On here now, you're gonna put the apical, you're gonna put what here? Systolic.
systolic.
Then over here, you're gonna put diastolic. And then over here, you're gonna put widening pulse. And over here, the comment. So everything is
On
just,
A systolic, on diastolic.
A, C, die. And the other one is
Diastolic. Diastolic.
the other one is
Widening
winding.
pulse.
Is W.
All right.
Come go take my blood pressure.
Take out your blood pressure, guys. PD.
Systolic.
Under PD, widening pulse.
It's systolic, diastolic, right? The winding pulse. Help.
Wipe it now.
I don't have to wipe it because it's brand new.
Under the A is
It's brand new.
systolic. That's systolic, that's why, right?
That's why I talk to my residents. It's brand new. I just bought it.
And diastolic. And then under the CD is winding.
Something by 80.
I mean, window.
She asked me.
Come in sa kule na ko iki ako sa.
Bakin mo mali.
That's my neighbor.
So,
Oba mother ask him. Very nice.
Okay, don't talk when you're getting your blood pressure. Don't talk. Don't talk when you're having your blood pressure checked. You're getting the wrong reading.
If you have time, sir. Right? Right? You agree with me?
she be down here, right? Okay.
No, not this. Not this. Not this. You're the patient. You can't be doing it for yourself. Yeah?
if they call it deficit, they may not have right? But one thing is what you remember,
Hey! Not this.
That high?
What's going on?
It's true.
What's going on?
Take it.
Talk to me. What's going on?
It's true.
Let's try the other hand.
Oh my God.
Yeah. You are nervous. Stop being nervous. You're just a man.
No,
Stop being so nervous.
because I received it today.
Which one shows you?
No,
Which one
I
shows you?
received it
You took blood today? Stop drinking blood.
It's true.
Relax.
So do you put it wrong?
Don't worry, I know what I'm doing.
You know what you're doing?
I'm an RA. I'm an RA. I know what I'm doing.
Oh, please. Upside down, I'm a
I know what
patient.
I'm doing. I'm an RA.
I'm a patient, you may
Don't
come.
question me. I'm an RA.
I'm a RN too.
I'll put you in jacket. I'll put you in jacket. Okay. You're right.
Just for the sake of it, just for the sake of it, because I had just for the sake of it.
Okay, because I'm always low.
Yeah, just for the sake of it, I want to do it.
Because my low is low, like 120 or 110.
Right here.
Guys, learn to do a proper blood pressure.
140 over.
People have lost the ability to do manual blood pressures
140 over.
because they're so accustomed to putting on what?
Alright. Mechanical one.
The ones that is with your Welch Allen, vital signs,
Wash your hands.
all along the wheels.
Blood pressure, that's my, listen, I'm hypertension. Okay. I'm high.
Oh, you are? Oh, no wonder. Where's your
That's it?
your comb?
You want to take me?
Let me try you.
I don't have it.
That's why you think you got a question.
C'est sous compte moi ici. Et on peut moi pour plus facile. Dr. Etienne, come and take me now.
This is best for you to have
Take mine, Dr. Etienne. Why you choose the Etienne? I choose Etienne.
I didn't even choose. You see that?
Guys, you gotta relax. Your blood pressure fluctuates quite easily. You could be talking to somebody and you could get upset and your blood pressure will go up. You can be having somebody who's good looking over you and next thing you know your blood pressure goes up.
No wonder. My blood
So
pressure.
that's the only post.
My blood pressure is
You will not be good.
Farrell, stop raising my blood pressure, okay?
Yeah.
It was my nest, not this body, it was my nest. When you find the blood pressure, the systolic and the diastolic, that's my nest. Very bad.
Is your nurse?
I'm just kidding. If you guys have any problem, let me know. We can fix it.
Mr. Wesley, this nurse, I want to complain.
Sometimes you gotta walk away.
Why should we do this?
That's not the case, right? Why didn't we, why didn't
My name is. Remember, again, I'm not kidding now. Persons who might be doing an activity, persons who might be getting upset to something they hear, can make a blood pressure go up. So try to be calm, try not to get yourself upset when the person is doing your blood pressure, alright? Make the person who is doing their blood pressure, make them feel relaxed.
Like me.
Like anybody, make yourself feel relaxed. I can't.
Yeah, I know. Everybody do yours?
Fairly because we have to compare.
Come.
Let me do you. Cause this one here. Hey, Chineke. She will kill me before my time. I don't want you in my nursing home.
Do not talk, okay?
Here, sit down.
Talk.
When you guys already got your sets from standing, but one of the things you want to do is if you don't want to get a small cup, those small cups are mainly for children and people who are very thin, right? So usually ask Stanley if he has the one with a medium or large cup, but don't take the small ones.
I'm the nurse. I'll take care of you. Don't worry. I'm good nurse. I will not let you die. Okay?
A little 200, right?
Thank you.
That was a beginning.
That's it.
But it's one of them.
Right.
What's that page?
When you join, I will start you on books.
Yeah, I got one.
Okay. 120. 586.
No,
You never touch woman?
Okay.
Because the books here
The words was not like the top one. Like, okay. The population minus 106 to 66.
Sure, you're here what you're supposed to hear. Okay, for those who have already did it, I want you to look for what caused vital pulse. What's the cause?
Raining clothes.
Cranial pressure? ICP?
Where's my bag?
But see what it tells you there. Or why the
Oh shoot.
Stiffening, those kind of stuff.
going down, but what's showing you that they have different teeth, different underlying causes.
You're not making severe. No. It's gonna be a little while when you return. It's gonna have the teeth, you're gonna have but I'm not having a you wanna take one?
What was the
I did yours first. You're the first one I did. And you told me it was high.
Yes.
Let me do it already.
Why is it not? It's in the absence
If you have to
No. That was a liar. What time is it? Mercedes, what time you got?
But they say you can increase it.
Tell me about
Levels of iron, no fair eating in your life. Give him the paperwork.
I think so. Huh?
Give him the paperwork.
Let me see your pen.
My pen? I don't have one now. This is it.
So we have to read. Me too.
I'm waiting on the sheets.
Yes. Willie by exercise. My teacher there.
Hey, give me a good one.
Yeah, where's my phone? Yeah.
Oh, not that.
Where's my phone?
Come on, guys, I'm working on these sheets of paper.
You see that?
Here.
Blood pressure?
145 on pulse deficit. One of the things I hope you took notice of, guys, listen please. I hope that everyone took note of the apical pulse, how we do it. We did a carotid pulse, we did a pulse deficit, and we did a vital pulse. That is not just about doing the pulse.